Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, health insurance. Jonathan Cohn is a journalist and author known for his extensive writing on the healthcare system and the politics surrounding it. Today, he joins Stephanie Desmon to discuss health insurance. What do recent government cuts mean for people who can no longer afford it? Why is healthcare in many countries considered a basic right, and why has that never been the case in the United States? Let's listen. Jonathan Cohn, thanks so much for joining me.
Stephanie, thank you. I am a huge fan of this podcast, so I'm very excited to be on it.
I'm a fan of yours, so the admiration is mutual. I wanted to talk today about health insurance in America, a very big topic, obviously, to cover in a short amount of time. When last I spoke about this on the podcast, there was a great concern that the subsidies that had been given to people who have Obamacare, which is from the Affordable Care Act insurance, that they were going to lose their subsidies and that many, many millions of people would likely be unable to afford health insurance anymore. I also know that the government shut down over this last year. So I'm wondering if you could give a quick look at the landscape of where those subsidies are now and what's happening to people.
Yeah, sure. So just to sort of set the stage, the Affordable Care Act has a bunch of different provisions in order to make insurance more available to people who don't have employer coverage or make too much money to qualify for Medicaid. We created these insurance exchanges. If you buy insurance this way, you know it as healthcare.gov or maybe Covered California if you're in one of the states or some other state where they run this market themselves. And the deal is these are where you can get policies available to anybody, regardless of pre-existing condition. You're guaranteed comprehensive set of benefits, and you are eligible for financial assistance. The idea is we recognize that insurance is very expensive, even more so if we're making sure it's good insurance and it can cover anything you need. A lot of people can't afford it, so there's financial assistance available. In 2021, as part of the pandemic response, and at this time, Joe Biden was president, Democrats had a majority in Congress, they added an extra layer. They basically said, we're going to give an extra boost. We're going to give you extra financial assistance. Now, the sort of impetus for that was COVID. They were like, look, it's a pandemic, it's an emergency. We could do anything we need to do to get people health care. But behind that was a sense that even, for 10 years, the people would pass the Affordable Care Act because of all the compromises that went into the bill and getting the votes. They always felt like they had not made that assistance generous enough. And it was one of the reasons that even after the law took effect, you had so many people saying, it's great, I can get coverage with my pre-existing condition, but wow, these deductibles are really high and it's costing so much money. So they added this extra layer of subsidies, enhanced subsidies, they called them. And they had an immediate effect, and it was dramatic. Enrollment in the exchanges, healthcare.gov and the state exchanges, basically doubled because now there was this extra money. Insurance got cheaper. So either you could spend less money on your coverage, it became affordable, or in a lot of cases, people said, oh, the insurance is more affordable now. I'm going to go from a plan that has a $7,000 deductible to a $2,000 deductible, which is obviously a huge difference. So that money was put in place, but it was temporary. It was set to run out at the end of last year. Democrats said, hey, we like the fact that all these extra people are getting insurance. We think this is a good thing. We want to renew it. Republicans said, wow, this is a lot of money. And it is. It is more than $30 billion a year, give or take, kind of costing it out over the future. And they said, this is a lot of money. We don't really think we're getting a lot of bang for our buck here. We think there's a lot of waste and a lot of fraud. This is the standoff they had. Democrats felt so strongly about it. They said, we're going to shut down the government and demand a vote on it, demand these extension. They finally got a vote on it. Didn't pass. After that happened, they were able to, in the House, led by Democrats with a number of Republicans joining them, they were able to pass a bill that would extend the subsidies for 3 years and, so basically put the money back. But now, that means the Senate would have to pass it also. The Senate rejected that bill specifically. A group of senators, bipartisan group, has been working to try and find some kind of deal that everyone can agree on. The hope is they get it, because remember, in the Senate, you need 60 votes, not just 50 because of the filibuster. So the hope has been they would be able to come up with some kind of deal and send it back to the House, and hopefully it would pass there. At the moment, as of this taping, things look pretty grim. Even the optimists on Capitol Hill are pretty pessimistic. I've been covering healthcare long enough to know that nothing ever actually dies when it comes to healthcare legislation. It can be declared dead and buried and then zombie-like, come back up 3 months later. But it looks pretty grim right now. I mean, I think the overwhelming likelihood is that the money will not be put back. And we're already seeing effect with many people, seeing premium increases of hundreds of dollars a year, thousands of dollars a year. And of course, some of these people are just going to say, that's too much. I'm just not going to get insurance at all.
And I was going to ask you about the effects, like the impacts on people. So we're going to see people who can't go to the doctor.
Yeah, I mean, it makes a difference, right? I mean, people, when you have health insurance, you feel a lot more confident to go to the doctor because, let's say when you think about it, right? I have an ache, I have a pain, I'm going to go see the doctor. Chances are pretty good that the doctor's going to say, you might have this condition or you need a certain procedure. So now you're getting into more bills. And if you don't know where you're going to be able to pay for those bills, you're going to be a lot less likely to get that care. And we have data on this to sort of show that people, when they have insurance coverage, are more likely to get care. Among other things, when you have health insurance, you're more likely to develop a relationship with a primary care provider, which, as I'm sure a lot of the listeners of this podcast know, is such an important element in getting good health care. Because, primary care visit's expensive, right? You get a checkup, it could be $100, it could be more. And if you don't have the insurance to pay for that, you're probably not going to go because you'll say, well, it's something I can put off. And of course, we know just as a reality that when you talk to people who don't have health insurance, it is frequently people who are in between jobs, for example. And I mean, I've seen so many cases like this where someone says, they lost their job, they lost their insurance. So they're uninsured. And they say, well, I'm going to get a job at some point. I'm going to find new work. And so I'm going to put off my medical care until then. And then what happens is maybe it takes them a while to find a job. And maybe they find a job, but it's part-time work or it's a contract job. So they don't have health insurance. And so now it's 6 months, it's a year, it's 3 years. And it happens. I've told real life stories of people who were in that gap for 2 years, 3 years. And that's when they missed early diagnosis of a cancer and it ends up being fatal. I mean, these tragic stories really do happen. The Affordable Care Act, the hope from the people who passed it was to, reduce and eliminate that. And it certainly reduced the incidence of that, but it didn't completely eliminate it, take away the subsidies. And it is reasonable to assume we'll see more people delaying care and, down the road, more people suffering more health problems.
So as you're talking, I realize that this is really a very uniquely American problem. In the United States, health care comes with your job, basically, or it doesn't come with your job. And then you don't have it. You recently traveled to Japan, and I'm wondering if you could tell me some of your insights on how things are different there than in the United States.
Yeah. So Japan has a universal healthcare system. And let's be clear about the definition. I think some people hear universal healthcare and they think that means what we call in this country Medicare for all, which is something that's associated, with Senator Bernie Sanders, which is the government directly providing insurance to every person in the country. Those systems exist in some countries. It is a way of achieving universal coverage, but there are other ways to achieve universal coverage. You can do it through a mix of private plans and public plans where people are shopping around. You can do it through a system where there's like a baseline government program and then people buy private insurance on top of it. It really, if you look at 10 different countries, you'll find universal coverage in 10 different varieties. Japan is an interesting hybrid system where basically most people will get insurance through their employer. If you don't get it through your employer, then there will be a kind of government program of some kind, typically run by the municipal governments that manage them. So in that sense, it's a kind of what a healthcare wonk might call a multi-payer system. But in reality, the insurance looks exactly the same, almost exactly the same, no matter where you are. You'll just, when you move from one job to another, sometimes you'll change whose name is sort of processing the payments, but the insurance looks very similar. And the sort of things that struck me about Japan, two things really stood out. I think when you talk to people about universal coverage, there's a fear that, oh my gosh, if we have universal coverage, I'm going to have to wait a long time. That I won't have access to the latest treatments. And that is an impression that comes from some countries where, in fact, it is very common to wait a long time, say, for specialty care, or they might really they may limit access to the most advanced treatments or be slow to adopt it. It so happens that the two English-speaking countries that most Americans know best, the UK and Canada, both have elements of that, although I will say all systems have their pluses and minuses, and there's a lot of great things about the Canadian and the British healthcare systems too, so I don't want to be insulting them here. But it is true that for specialty care, you can frequently wait a very long time in Canada and the UK. It is not true that is always the case in the universal coverage system, and Japan is a great example of that. They really pride themselves on speed. They don't want people waiting for care. And in general, you do not see long waits for care in Japan. If you want to see the best endocrinologist in Tokyo, sure, there's only one best endocrinologist. He's got a long or she's got a long wait list to get in there. But if you want to see an endocrinologist or you need a procedure, you'll be able to get it pretty quickly in Japan. And again, their system has its pluses and minuses like everybody else's does, but in terms of speed, access is just not a problem there. And then the other thing I saw in Japan, and this is something I've done this in about a half dozen other countries over the years. France, I've been to the UK, the Netherlands, Taiwan, Canada, and studied their healthcare systems. And the one thing is, you talk to people in any of these systems, and you're like, our healthcare system has this problem and that problem. I think it's a universal condition to complain about your healthcare system and list off everything that is wrong. And then you ask them, you say, so do you think universal coverage is the problem? And they'll look at you funny. I mean, it is just, the idea that everybody should have health insurance, that it should be a right, is just taken for granted in these countries. It is not part of the political debate. They will have very intense debates about how much to spend, how to organize their systems, whether to be more private, more public, how much they're paying the hospitals, or the doctors this. You go down the list, what's going on with prescription drugs. But in these countries, there is no mainstream politician or political party suggesting they back off universal healthcare. It is taken for granted. It is assumed to be a human right. And if you ask them, would they ever give that up? They will literally look at you funny, like, why would we ever give that up? That seems like such a normal, just baseline for discussion.
So why is that not the norm in the United States? Is it money?
Well, it's a complicated story, as things in healthcare tend to be. Part of it I do think is, American political culture is unique. I mean, every country's political culture is unique, obviously, but in America, we have a very strong strand of individualism, a kind of aversion to sort of anything that sounds collective or communitarian or whatever word you want to put onto it. In addition, we got on a path early. We went on a path of rejecting universal coverage. I always say, people say, is there a moment when we could have gotten universal coverage? And I say, yes. You want to go back to the 1930s. You want to go to the White House, get in there in the Oval Office with FDR when he's crafting the Social Security Act, thinking about adding health insurance to it and say, please, please, please add it. Because if they had done it then, health insurance was kind of itself was like a new thing. It hadn't really existed before the early 20th century. And if they had just added it then, which is what some countries did, they did it as part of their sort of social insurance packages, we would have gone on a path and we would have stayed on that path. But we didn't. And because we did not, because there were financial problems, there was a need to pay for healthcare, the private sector created its own system, and then the government kind of got behind it, and there's a whole story of this. But basically, this system of linking insurance to your job really took root in this country, and it took root in a way that helped fuel resistance to a kind of universal coverage system. I mean, the really first serious push for this was when Harry Truman was president. And one of the arguments against it was, well, we have this private insurance system. It seems to be growing and working well. And this was the Cold War. People would say, well, universal coverage, that sounds like a communist thing. We don't want that. And basically, we kind of went on that path. And there's a phenomenon in political science called path dependence. It's just like it sounds. Once you start going in a direction, it's real hard to get off it. And it makes sense, because the bigger the system gets, the more people are invested in it, the more industries are invested in it, the more groups that are invested in it. And to get from that to a universal coverage system, almost inevitably, you're having to rearrange things, you're having to move money around, and that is not something anybody wants to do. You throw on that the fact that, the public in general, people are afraid of change. They may not like people will say, I don't like the American healthcare system. Great, here's an alternative. Oh, wait, that might change my insurance. I'm not sure I actually like this better than what I have, or I don't trust it as much. Throw on top of that all the sort of familiar dysfunctions of American government. It's very hard to pass big laws in this country because we have two houses of Congress, and then we have a president. You got to get through all three. You got to clear the courts. We have a federalist system with federal and state. It's just very hard to do this kind of big change in this country. And those are like the explanations for it. Beyond that, I think I have sometimes thought we're kind of just at least conceptually moving to a place where most Americans believe healthcare should be a right. And I think the polling on this it's hard to tell because it depends on how you word the question. You know how it is with polls. I think most Americans do think healthcare should be a right, but it's not. They don't feel about it the way they do, say, in Europe. And you'd have a sizable contingent in this country who do not believe that, who think, I think it should be an individual responsibility. It's not, as somebody who pays taxes and is part of this community, I don't think it's my responsibility to make sure everybody has healthcare. I shouldn't contribute to that. It can be done in sort of smaller groups, but I don't think the government should be, either I don't believe it should be my responsibility, or I do not believe it is proper or wise for the government to kind of set up a system where that happens. So, that's where we are.
So the research does tell us, I imagine, that healthcare makes for healthier communities.
It does. It's been interesting. The Affordable Care Act passed in 2010. And a few years after that, and part of the Affordable Care Act, a big part of it is this expansion of Medicaid, where basically Medicaid is like everything else in the American healthcare system, it's complicated, but the federal government pays for the majority of it and sets out broad rules, and then states manage the program and kick in some of their own money, and they have some flexibility over how to do it. So the expansion of Medicaid, which used to be varied a lot based on state to state, and many states only narrow groups of people applied. Affordable Care Act really expanded it. And the idea was that everybody with incomes at poverty line below it or a little above it would become eligible. We didn't quite get there because the Supreme Court got in the way and changed the law, ruled one part of the law was unconstitutional. So some states still have not expanded Medicaid, but most have. It's the single biggest reason the number of Americans without insurance has come down is the Medicaid expansion. Now, it's very expensive, costs a ton of money. And, this is one of the criticisms of it is that we're spending so much on this program. Is it worth it? And there was a really important study that came out. I want to say it was 2013. Don't quote me on that year, but people will know it as the Oregon Health Insurance Experiment, based on some experience in Oregon where they had that rare thing you get in social sciences, where they had basically a random experiment, because Oregon had a limited amount of money to expand Medicaid. So they held a lottery, and some people got it and some people didn't. So right away, you get a nice little experiment there. You can follow these two groups of people and see what happens. And when they studied this, they came out, a really big finding was they could not find proof that expanding Medicaid reduced mortality. And that got a lot of headlines. And it caused a lot of people, even people who were in favor of Medicaid expansion, to say, hey, wait a minute. We sort of assumed that was happening. I mean, intuitively, right? You think, you get insurance, you're going to end up healthier. And a lot of people said that was, maybe we should question that assumption. Now, in reality, even people, as people pointed out at the time, the finding was a lot more nuanced than it sounded. For one thing, the finding was we could not prove a decline in mortality. It's not that they didn't find one. It's that death is a relatively rare event for younger people. And so you need, to get a sufficiently large sample size to tell the sort of effects on mortality is tough in one state. It was, in the sort of academic parlance, it was not statistically powered high enough to really find a mortality result. And meanwhile, they found all kinds of other beneficial results. They did find people were more likely to go to the doctor. They found people who had more financial security. More importantly, in the years since then, we've had a number of studies, including one that just got published last year, really comprehensive, using large data sets, some of them using IRS data, some using census data, just the kind of studies that had not been done before. And they have found a very strong relationship between getting Medicaid and health outcomes. And they do find that people are healthier and that they are more likely to live longer and avoid preventable deaths. And of course, that's for Medicaid, which anybody who works in healthcare or experiences it in some way knows that Medicaid is it's not a great program in a lot of ways. Among other things, doesn't pay a lot to the doctors and hospitals. It can be tough to find a specialist. But if we know that Medicaid is leading to good health, it's a safe assumption that Medicare, private insurance are also leading to good health. And that in general, getting people insurance is going to lead to better health outcomes, which, to be clear, is separate from the question of whether it's worth doing. You can do a cost-benefit analysis on anything. Paying for Medicaid expansion, paying to subsidize insurance through the Affordable Care Act, paying to subsidize employer insurance, which we do through the tax system, that all costs a great deal of money. It's a very legitimate debate to say, okay, yeah, there's some benefits here. Is it worth it? And that is really, I tend to think if we were having, it's so hard to have, calm, deliberative, civil debates in this country. But I feel like if we were to have one of those debates about healthcare, I feel like that's really what the crux would be. Like, we see there are lots of very clear benefits here. There is also a very clear financial cost to this. How does that net out? Are there financial benefits we're not seeing that maybe offset that, or is it just worth it? Or could we spend the money in some other way, or are we better off not spending the money? And that is that is the debate to me that we should have, and we sometimes pops up, maybe gets obscured in some of the other arguments we have in Washington.
Jonathan Cohn, thank you so much for joining me.
Thanks for having me. This was so much fun.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.